Hello, all, and welcome back to another NKF Live episode from National Kidney Foundation. I'm your host, Marlena Chesner, NKF's Digital Content Development Manager. Today, we are discussing hyperphosphatemia, or high phosphorus levels in the blood, a common issue for people living with advanced stages of chronic kidney disease, especially people with stage 4 or 5 CKD. I'm joined by Dr. Jay Wish, a nephrologist or kidney doctor who practices outpatient dialysis at Indiana University Hospital, Dr. Katie Cardone, a clinical pharmacist who works with patients living with kidney disease and those receiving dialysis treatments, and Quentin Turner G., a stage 5 in-center hemodialysis kidney warrior living with high phosphorus. Let's get started with some introductions. Dr. Wish, would you tell us a little bit about your work with people on dialysis?
Sure. So I'm medical director of the dialysis unit, which is located here at University Hospitals in Indianapolis. I also make rounds on about 20 patients in the unit, and the monthly rounds generally include a review of their chemistries, including serum phosphorus, their blood pressure, their dialysis prescription, their vascular access, etc. I feel that treatment of hyperphosphatemia and getting the phosphorus under control is probably the most challenging aspect of these monthly rounds. Most of the other parameters that we look at in terms of chemistries and other types of dialysis prescription issues are generally easier to manage than high phosphorus. It's a particularly vexing and challenging problem.
Well, thank you so much for being here, and we're excited to hear about your expertise. Dr. Cardone, what does your job as a clinical pharmacist entail?
Sure. So I am a faculty member at Albany College of Pharmacy and Health Sciences. And as part of my job, I have a position at a local outpatient dialysis facility. I work with patients, caregivers, and the rest of the healthcare team to optimize everyone's medication list. And so that entails making sure they're on the most appropriate medicines, they're on things that are safe and effective, and also on things that are affordable and that the patient likes and can use effectively. So we're talking about phosphorus here, and so we're going to talk about that there are lots of options to help control phosphorus, and my job is to help the patient get to the best possible medication regimen.
Awesome. Perfect. Thank you for being here. We're so excited. And finally, Quentin, could you give us a brief overview of your kidney journey?
So my kidney journey started back in 2020 during COVID. I was just really, really sick. I gained a bunch of weight and couldn't explain it. I was working out, eating right because I'm a former athlete. So things kind of took a turn for the worse, and I was hospitalized for a few months. And in that hospitalization, they did some testing, urine samples, blood testing, and that's when I was diagnosed with end-stage renal disease. And then I want to say towards the end of last year, I actually got a genetic test done, and I was diagnosed with APO1 mediated kidney disease, and I have FSGS.
Wow. Okay. And you also have issues with your phosphorus or have experience in managing it?
Yes, so that is the one thing out of everything with kidney disease we have yet to be able to get under control.
Backing up what Dr. Wish said about it being particularly vexing. So, Dr. Cardone, what exactly is phosphorus, and why do some people with later stage kidney disease experience issues with this?
Well, phosphorus is an essential mineral. It's found in all of our bodies. It's primarily found in our bones, but it is essential not only for bone health, but also for a lot of different functions of our body, including energy production. And so, like a lot of things, there's a sweet spot. Too little is not good, and too much is not good. People with advanced kidney disease have trouble getting rid of extra phosphorus. And so it does accumulate as kidney function worsens and lowers. And it's particularly difficult for people who have kidney failure or who are on dialysis.
And this is because kidney failure patients aren't excreting as much through their urine, correct? Perfect. Now, Dr. Wish, what issues can high phosphorus cause? And can you share some of the statistics about how common it is, especially for people on dialysis?
Sure. Virtually all dialysis patients, if untreated, will have high phosphorus levels. It's because diet is ubiquitous in terms of phosphorus content. Phosphorus is the major intracellular negatively charged ion in all cells, whether they come from animals or vegetables. You're eating cells, you're getting phosphorus. And under normal circumstances, if your kidneys work, you get rid of all the phosphorus you don't need, and your phosphorus level in your blood stays in the normal range. But just a normal diet contains more phosphorus than a failing kidney can handle, and also more phosphorus than dialysis can handle. Dialysis is not particularly effective. At least our conventional 3 times a week, 3.5 4 hour dialysis treatments are not particularly effective in removing the kind of phosphorus amounts that normal kidneys get rid of every day. So again, we don't think it's due to patients, doing terrible things with regards to their dietary habits. It's just normal diets that contribute to high phosphorus level. And the other thing is that a lot of dietary additives have a tremendous amount of phosphorus in them. And that's probably one of the major sources of the excess phosphorus that we deal with in dialysis patients' diet. It's not the grains and the dairy products that we know have a little more phosphorus than other normal foods, but it's the additives in, say, a Diet Dr. Pepper, which I happen to have on my desk because I like it. If you read the ingredients on a Diet Dr. Pepper, they go water, caramel color, aspartame, and phosphorus is the 4th ingredient. So there are just so many things that are on the grocery shelf that add phosphorus to improve shelf life, to improve taste, and these are all sources of the phosphorus that the kidneys can't get rid of if you have advanced kidney disease, and cause for the phosphorus level to go up. Now, you asked about what is the frequency of phosphorus levels if the patients are treated, and the answer is even with our best efforts in terms of dialysis prescription and phosphate lowering drugs, only 40% of dialysis patients are able to control their serum phosphorus, and about 60% still have high phosphorus levels.
Now that sounds very serious. So what issues can that cause?
Well, the major issues with regards to high phosphorus have to do with both bone health and vascular health. High phosphorus levels in the blood, and this starts even before you get on dialysis. It actually starts in late stage 3 CKD, and we've seen this as you go upstream in terms of the decline in kidney function. The elevation in serum phosphorus level that occurs even with EGFRs of 30 or 40 decreases the calcium level in the blood, because phosphorus and calcium like each other. They combine together. That's what causes the combination that produces bone, produces teeth, produces fingernails. All those hard things in the body are due to calcium and phosphorus coming together. And if your phosphorus level goes high in your blood, it decreases the calcium level in blood, and that triggers the parathyroid gland in the neck to make more parathyroid hormone, and that works on the bone to release more calcium to try to keep the calcium level in the blood in the normal range. But you pay the price for that in terms of the degradation of the bone and the weakening of the bones and increased fracture risk. The other side of the coin, however, is that the high levels of calcium and phosphorus combined in the blood deposits on the walls of the small vessels throughout the body and leads to increased vascular disease and can end up with heart failure, strokes, myocardial infarction, which is with heart attacks, and then the small vessel disease that can result in diabetic foot ulcers and other places in the body where the small vessels are adversely affected. So it can be a pretty nasty long-term complication.
Yeah, and since this is so common, I'm wondering, Quentin, when you first realized you had high phosphorus and you learned about all of this, how did you feel?
I was taken aback because, getting a kidney failure diagnosis is automatically, jarring. But then when you find out, you have all these high levels of chemicals in your body, and you don't know what to do about it, it sometimes it can be, what's the word for it? Disheartening. You can get kind of like to the point where you think, all right, well, this is never going to end. What can I do? Because it's been 4 years now, and my phosphorus levels, we're still trying to get them into a reasonably safe range. They're lower than where they were at one point, but they're still not at the level they want them to be at.
How do you maintain, positivity in the face of this?
Just doing things that I enjoy, being an advocate, speaking out, um, spending time with family, not letting anything get in the way of being a father. Just looking past the bad things that are going on, or not necessarily bad, but the things that are negatively affecting you and focusing on the good things. That way you're surrounding yourself with positivity.
That's a great answer. And now I'm wondering, Dr. Cardone, so what is the target range for phosphorus? Is it different from everyone, like from person to person, and what should they aim for?
That's a great question. So the normal range of phosphorus is 2.5 to 4.5 milligrams per deciliter. But we recognize that people with advanced kidney disease may not be able to get in that range and still maintain really good nutrition. And so our guidelines tell us we should be toward the normal range. There's not really a specific number that is given by the guidelines, but the healthcare team for a patient can help determine exactly where we want those numbers to be. The important part, I think, here is to make sure that we're keeping track of where we are. And so I really liked what Quentin said, that he's been following his numbers, that he's working with his healthcare team, that he's checking in. And so writing down numbers is important, and looking at trends. So are things getting better? Are they getting closer to where we want them, or are they kind of moving away? And this is important to make sure that the patients, their family, the team, we can figure out what's working best for an individual.
I love that, moving towards normal, which it gives you a little bit more hope that you can, manage these things. So, and speaking of management, Dr. Wish, what are some of the different strategies that people can use to treat high phosphorus? And then I'm wondering if Dr. Cardone would jump in afterwards with some summaries on the medications.
Okay, so let's start with diet, since I already pointed out how ubiquitous, how common phosphorus is in almost everything we eat, since it's in every cell that we digest. So you have to look at the foods that are highest in phosphorus content. Those are the offenders that you try to not necessarily eliminate from your diet, but try to decrease to a certain degree. And I mentioned dairy products and grains are probably the biggest group of foods that have a relatively high phosphorus level that to a certain extent you can cut down. The other thing is awareness of food additives and reading labels. Okay, this is extremely important. When you go to the grocery store, you pick up a bottle of something or a box of something or a can of something, look on the label and see where phosphorus, if at all, is listed on the label. And if it's listed in the first three ingredients, then that's going to be a problem, because that phosphorus is going to go into your body and it'll have a lot of difficulty getting out. For non-dialysis patients, before you get on dialysis, the stage 3, 4, and 5 patients, this is really the only option that we have, because we can't remove phosphorus with dialysis. And most of the drugs that I'll talk about in a couple minutes are not approved for non-dialysis patients. They're really only approved for dialysis patients. So if you're a non-dialysis patient and your doctor or your nurse practitioner or whoever says your phosphorus is starting to rise, then what you want to ask for is either a dietary consult to help you avoid those foods that are high in phosphorus. Get a guide of the high phosphorus levels from your doctor. Most of us have them in our office. I certainly do. Which foods to avoid, which foods that are relatively low in phosphorus that you can kind of substitute for the ones that you're staying away from. And this can be very, very helpful. Once you're on dialysis, then you have the two additional options. You have the dialysis itself. Dialysis does remove phosphorus. There's no question, but it doesn't remove enough. Because if it did, then we wouldn't be using additional therapies like phosphate-lowering drugs. It's very, very clear that the amount of phosphorus that's removed on dialysis is directly correlated to the duration of the treatment. The longer the dialysis, the more phosphorus you're going to remove. Interestingly enough, increasing the frequency of dialysis, say to 4 or 5 days a week, doesn't remove more phosphorus if those dialysis treatments are short. But if you extend your dialysis treatment from 3.5 to 4 hours or 4 to 4.5 hours, you will remove more phosphorus, and it may be easier for you to control your phosphorus with fewer drugs. So the longer the dialysis treatment, the better, no question about it. And then finally, we have the drugs. And there are two classes of phosphate-lowering drugs. The ones that most people are familiar with and the ones that have been around a long time are the phosphate binder drugs. They actually bind with the phosphorus in the digested food and prevent it from being absorbed. and it goes out in the stool, and it's as if the phosphorus wasn't in the food in the first place. And there are a variety of phosphate binders, and everybody has, different side effects or different likes and dislikes with regards to whether they're chewed, whether they're swallowed, etc. And my motto is the best phosphate binder for any patient is the one that they'll take. Okay, so it's clearly a patient-centered decision with regards to what phosphate binder to use. There's no one-size-fits-all approach. Finally, there's the newest class of phosphate-lowering drugs that actually blocks the absorption of the phosphorus by the intestine, and these are generally used in combination with the traditional phosphate binder drugs when the phosphate binder drugs don't get the phosphorus quite down to the target range, and this allows the patient's phosphorus to kind of get across the finish line.
Perfect. That was a great explanation. Dr. Cardone, did you have anything else to add?
No, I would just echo what Dr. Wish said as far as, phosphate binder selection. The biggest thing is finding something that the patient is interested in trying and will try to stick to. And you don't know what you're going to like or not like until you try it. So, there's liquid choices that are a bit easier to swallow. Some people really don't want another tablet to take. These tend to be larger in size, and, it adds to the pill burden and taking another medicine. Some are chewable, and for some people, they really love that it's, something a little bit different, a little bit easier. But others say they don't like the flavor, the chalkiness of a particular product. And so it really goes to what you're willing to do as a patient, as a caregiver. The other thing is trying to make it as easy as possible. For example, if you pick up phosphate binder prescription from the pharmacy, oftentimes you're getting giant vials or bottles of phosphate binder. And so I usually tell patients to ask for a separately labeled small vial that you can throw in your purse or pocket so you can take them with you when you're leaving home, to remember if you eat away from home often to bring them with you. But yeah, I think there's a lot of things kind of working through what the difficulties each person is having. Sometimes people don't want to take all of their tablets at once. And so I say, take one before your meal, one during your meal, and one at the end. Try to space it out throughout the meal, if you will, if it's too much to swallow all 3 tablets, if you're on 3 per meal, for example, right at the beginning.
That's some great advice, especially, asking for the little travel size. Now, Quentin, how does living with high phosphorus affect your life and daily routine? And have you used any of the strategies that the doctors have mentioned?
Yeah, so it's a pain in the backside, because, like they said, you're constantly reading labels, and that can be tedious. So when I go to the grocery store, I try not to pick up anything with phosphorus or phosphate or, the other names for phosphorus on it. But it's hard because phosphorus is in practically everything that we consume. So just making sure that there's not necessarily like a blatant phosphorus label on it, while also trying to eat uh, fresh as much as possible, or like frozen vegetables, no canned vegetables. That try to stay away from those. Um, so I was on binders, and I didn't know about the liquid binders, so I might have to look into that. But I was definitely on the chewable binders, and it just kind of got to be one of those things where if I'm going out with family, I don't want to throw 3 thumb size, chewables in my mouth before, sitting down to have Olive Garden for lunch. So sometimes it would get to the point where I'm like, okay, well, it's not working anyway. What's the point of taking it? But then you have those days where you're worse off without it than you are with it. So I just recently started taking a blocker. So we're going to see how that goes. But so far, so good.
Do you have any go-to foods that are lower in phosphorus that you enjoy?
Um, Well, for me, it was mostly the drinks because prior to starting dialysis, I drank a lot of Gatorade and, Dr. Pepper, and that was my drink. And so I tried to switch towards more like organic drinks. Like I drink a lot of Lemon Perfect, lemon water. It's hydrating. It's water. It has coconut water in it too. Or just plain water. That's good. Buys are good. Um, Food wise, there's a long list of things that I can't eat. And I'm on two different diet plans for two different things. So I don't think that specifically there's any food that I kind of gear towards other than, fresh, fruits and vegetables like carrots, celery, broccoli. I like olives. I'm pretty sure I'm not supposed to be eating those, but they're like a hard no. If I can't have it, yeah, we're gonna have to stop this.
Now, I'm wondering, Dr. Cardone, what are the risks of living with untreated or undertreated high phosphorus?
Yeah, I think kind of to pick up where Dr. Wish kind of he mentioned these a little bit. So there's two main things. I think we're worried about bone health, ensuring that our bones are not more likely to fracture, and is one aspect here. And the other aspect is the deposits that can happen in the blood vessels. So as was mentioned, calcium and phosphorus love each other and they make deposits. They kind of go anywhere the blood goes, they can find themselves. And so, ensuring that they're not doing that means getting your phosphorus under control as much as possible.
Makes total sense. And on keeping it kind of maintained, Dr. Wish, how do you recommend that people go about checking their phosphate levels and kind of having these important discussions with their healthcare practitioner?
Well, for dialysis patients, this is automatic. If you're in a dialysis center, then they're going to automatically check your phosphorus every month. Whether you're on in-center dialysis or home dialysis, you will get a phosphorus level. You usually have a visit with your dietitian every month, and normally the dietitian will go over each of these values with you and provide recommendations in terms of dietary modification. And our dietitian also provides me with suggestions with regards to changing the phosphate binder if it's not doing a good job or raising the dose. So my dietitian is absolutely invaluable in getting that information to me with regards to the success or the failure of any particular phosphate lowering regimen, including diet. And as I said, dialysis is important and phosphate lowering drugs. So we have a great dietitian in my unit. I'm probably spoiled.
Quentin, how was it for you to interact with your healthcare team about this topic?
I don't mean to brag, but I like to say I got some of the best people on my side. From my nephrology team to my awesome dietitian, even down to the social worker, because it's a team effort, especially when trying to get access to things like Dr. Wish said, there was pre-authorization that was needed, and the social worker does everything she can to try to get the insurance companies to cover it, and when they can't, we kick it back to the dietitian who, when the dietitian gets the paperwork from the company needed for the assistance, they get it to you immediately. They point out where you need to sign, you fill out all your information, and then, the connections that dietitians have with pharmaceutical companies also are beneficial to patients. I get my medication shipped in the mail. I get mines on mine's is a 6 month supply. So I get mine's shipped twice a year. So every 6 months I get a big box of phosphorus binders. So I'm hoping with the blockers that will eliminate that need. But it's a great thing that it's finally getting covered after all the work that companies like NKF, AKF, AAKP have all done for patients.
Absolutely. And as we are running out of time, I'm just wondering if any of you have words of advice for those who are at risk of high phosphorus or for those who already have it. I think, Quentin, we should start with you.
Um, all I can say is trust in what your doctor tells you and believe that it's not your fault. Because a lot of times we'll blame ourselves. We're like, oh, I shouldn't eat this, or I did this to myself. And then you get into that depression and that self punishment. You can't do that. Kidney disease picks on everybody and anybody. It doesn't have a name, it doesn't have a label. You know, if it's your number, it's going to punch your ticket. So just stay confident, listen to what your doctor say, and do exactly what they say when they say to do it, because they're the ones with the degree and we're just living in their world.
Dr. Cardone?
Yeah. So I had a family member on dialysis in the last few years. And, I guess one of the things that is really important reflecting on that, and also on something Quentin said, is that you have to figure out, as a patient or caregiver, what's the most important thing that you're not willing to give up, or that's most important as you look for treatment regimens. What foods are you unwilling to, or you really don't want to give up? What's important from the medication regimen, because one of the things about dialysis is a big aspect is about quality of life. And so, kind of thinking about all of that together, talking about that with the healthcare team, the dietitian, the social worker, if you have a pharmacist, of course, the nurses and the nephrologist, so that the team can get on board with, hey, I'm not willing to give up this one food, or I really don't want to take another swallowable tablet, or I can't afford one more new prescription, whatever it is. I think sharing that information with the healthcare team is going to go a long way.
I think that's such good advice, to have those open conversations. And Dr. Wish?
Let me say a couple words about the non-dialysis patients with advanced CKD who may develop hyperphosphatemia, high phosphorus levels, before they go on dialysis. Again, we don't have a lot of options for treating this other than diet. But I think it's important for each patient to discuss their phosphorus when they see their nephrologist or their provider, or nurse practitioner, physician assistant. We get what's called a renal panel. It's a kidney function chemistry panel every time we see the patients with advanced CKD, non-dialysis. And that includes a phosphorus level. We don't have to order it separately. If we order blood tests, it's always going to have a phosphorus on it as part of the package that we get for these patients. So, they have the results. Your nephrologist or your nurse practitioner or whatever who's taking care of your chronic kidney disease will have a phosphorus level on you, or will get it after your visit if you get your labs right after the visit. So they will have the result. And this is something that you want to discuss with them. How is my phosphorus doing? Of course, you want to know what your EGFR is and how's your blood pressure and all that other stuff. But how's my phosphorus? Is it still okay? Is it starting to drift up? And if it's starting to drift up, ask them for dietary counseling. See a dietitian. Get a list of the high phosphorus foods to avoid and the low phosphorus foods to eat. The things that are on the low phosphorus list are actually pretty good things. I mean, they're fresh fish and fresh poultry and things like that, which are very nutritious. They give you the protein that you need, for cell repair and to, decrease the risk of protein malnutrition. And they're relatively low in phosphorus as compared to other foods. So, seek these things out.
Well, thank you all so much for joining me today. This has been such valuable information and a great conversation. To those watching, if you have any questions that we did not get to, please post them in the comments section of the social media platform you're using to watch this program. We will do our best to answer them within the next few days. Thank you all for tuning in and sharing your time with us. I'd also like to thank our sponsor, Ardelyx, for their generous support in making this program possible. On behalf of the National Kidney Foundation, I'd like to wish you all good health.